Welcome everyone. Today I am talking about advanced trauma life support. We will talk about some concepts of advanced trauma life support. ATLS is a program that designed by American College of Surgeons, and we are not talking about every detail of it. We are just talking something that helps you to treat and save the life of the trauma patients in the emergency department. The primary survey should be repeated frequently to identify any deterioration in the patient's status that indicates the need for additional intervention. So when you do ABCD, you have to repeat it, and frequently you repeat to see if there is improvement or there is deterioration, or then if there is any additional intervention that needed. So once patients with trauma come to emergency department, ABCD should be done, and then after that, when the patient becomes stable, then the secondary survey done. Of course, before the patient arrives, you have to have standard precautions to prevent transmission of infection, like cap, gowns, gloves, mask, shoe cover, protective eyewear, face shield. This is all to prevent transmitting of blood transmitted infections. The primary survey and the resuscitation of the vital functions should be done simultaneously. I mean, someone is caring about the airway, someone is caring about the breathing, another one putting cannula, another controlling bleeding. So there should be a systemic or a team approach to do this. But we are talking about ABCD in order to see which one is prior to the another. Before everything, the initial assessment, you have to prepare yourself. I mean, prepare your equipment, prepare your personnel, prepare the resuscitation room. Then, when the patient arrives, you have to do primary survey. You do ABCDE, and at the same time, if you see any life-threatening problem, you resuscitate the patient. For example, if the patient is in shock, you give IV fluid. The adjuncts that you are using is the thing that helps you in management of the patient or detection of something. For example, pulse oximetry to detect if the patient is hypoxemic. Then when the primary survey and resuscitation done, you have to re-evaluate the patient whether improved or not. If not improved or deteriorate, you have to continue primary survey. But if the patient is improving, then you go to the secondary survey. In the secondary survey, you take a simple history. You take you have to examine the patient from head to toe. Then you do neurological examination. You do more investigations like CT. Then re-evaluate using some adjunct. After that, if this is completed, then re-evaluation, and then definitive care. The definitive care might be a surgical intervention or, for example, a back slap, something like that. You have to be noted that sometime during primary survey, there is a condition that will not allow you to continue to the secondary survey. For example, a patient has an internal bleeding in the abdomen. So during primary survey, you have to give fluids and blood, and at the same time send the patient for operation room to be treated by the surgeon, because the patient is not stable and needs definitive intervention before going to the secondary survey. What is a quick, simple way to assess a patient in 10 seconds? How you assess a patient? Very simply, you have to talk to the patient. Ask the patient his or her name. This is a closed question. Then you ask an open question. Ask the patient what happened. He will tell you about what happened, and this indicates the Glasgow Coma scale of the patient. If the patient is responding to you, it confirms that airway is patent. There is enough air to to permit speech. It means breathing is also good because there is a good breathing. There is enough circulation, sufficient perfusion because there is enough blood going through the pumping of the heart to the brain. And there is clear sensorium. Also the Glasgow coma, all other things are good. So what is the primary survey? Primary survey, again, we are talking about trauma. In primary survey for trauma is airway plus C-spine protection at the same time. Breathing plus, if the patient is not breathing, you have to ventilate the patient through ambo-bag or assisted ventilation. Circulation plus hemorrhage control. At the same time, you are putting cannula, giving IV fluid, and at the same time, you control the major hemorrhage. Disability mainly means neurological status of the patient, or mainly brain. Exposure, you expose the patient to see anything that been missed, and also environmental control, especially you prevent hypothermia by recovering the patient. So this is primary survey. During this primary survey, you found anything that is life-threatening, you have to intervene. Okay, the priorities are the same, the ABCD for all the patients, whether a pregnant lady, a baby, an elderly. But there are some considerations. For example, this pregnant lady, when they come with trauma, there are two people you are treating, the baby and the mother. For example, you are doing the primary survey for the mother. Then after that, after primary survey, you have to manage, or you have to focus on assessing the fetus. And after that, you are doing secondary survey. Always priority is for the mother. You have to think that their airways might be swollen. When you put chest tube, you put at a higher level because of the diaphragm, which is much upper. And if the patient is having gravid uterus more than 20 or 24 weeks, the gravid uterus might press on the inferior vena cava. So example, this is the abdomen, and this is the vertebra. This is the inferior vena cava, and this is the aorta. So the gravid uterus, if the patient lying on their back presses on the inferior vena cava, it would not let to blood flow to go back to the heart. That's why you have to put the patient on left lateral position, or 15 to 30 degree tilting, in order to prevent supine hypotension syndrome. So these are the considerations. There are many other considerations. In an elderly man, for example, this patient is having trauma. It is true that you are going through the ABCD, but just think that this elderly might have other comorbidities like asthma, COPD, heart failure, renal failure. So you would be much cautious about giving fluid. You are thinking that this patient might have anticoagulants, antiplatelet like aspirin and clopidogrel. So you know that there will be much bleeding if they have an internal bleeding. Also their bones are osteoporotic and things like that. So you have to think special considerations about elderly people. Infants and children. In infants, they have larger body surface area. They are much liable for hypothermia. Their airway is small, liable for obstruction. Their bones are very fragile. For example, in the chest, there might be a lot of intrathoracic injury without rib fracture. We talked about pregnant ladies. Obese people have their issues of fractures and missed intra-abdominal bleeding because of difficult assessment. Athletes, they are usually have a normal baseline bradycardia. So their normal heart rate might be 45, 50. So if they are in shock, their heart rate reaches 80, which would appear to be normal to you. Another thing, okay, so we come to the airway. You have to establish a patent airway. A patent means an open airway, And along that, you have to protect C-spine. Someone to put a C-spine protected, and someone have to ensure a patent airway. Some people have progressive airway loss. For example, in a burned patient, if the airway burn happened, the patient might be normal in early stage, then later on they will have hoarseness of voice and obstruction of their airway, and they may die because of airway obstruction. Equipment failure, you have to anticipate that sometime your laryngoscope is not functioning. You don't have an appropriate size oropharyngeal airway. So things like that will happen always. Inability to intubate. This is especially a problem for anesthetic doctors or intensivist doctors. Sometimes they may face a very difficult airway. How do I know that an airway is adequate? If the patient is talking alert and oriented, so talking normally, there is no evidence of injury around the head and neck, you have assessed the patient for deterioration, so you say this airway is good. How do I know that an airway is not good? Or what are the signs of symptoms of airway problem, of airway compromise? You have to suspect it, have high index of suspicion. For example, a patient have a burn to the face, have also lip swelling, changes in the voice or sore throat, noisy breath like snoring or stridor, shortness of breath, agitation because of hypoxia, tachypnea, abnormal breathing pattern, and also low oxygen saturation, which is a light sign. So this will tell you that my patient is not good. When to intervene in a patient with patent airway? If a patient have impending airway compromise, so when there is airway problem, also you intervene the airway if the patient is not breathing well. So you may intubate the patient in order to give adequate ventilation. Also, inability to protect airway. Sometimes the airway is patent, have no problem. There is no swelling, nothing. But for example, disability problem, the Glasgow Coma scale is 8 and less. So at that time, you are suspecting that the airway, that the gastric contents may return to the lung and may cause aspiration pneumonia. That's why you have to protect the airway by intubation. So not only airway problems need intervention. Airway problem, breathing problem, disability problem may need intubation and intervention. How do I manage the airway? How do I manage the airway of a trauma patient? Of course, the first thing you have to give supplemental oxygen through a face mask that's connected to a bag valve. This would provide almost 100% of oxygen. It is better to be 15 liters per minute in the early stages of giving oxygen. You use basic techniques. I will show you videos about basic technique, which are chin lift and jaw thrust. Basic adjuncts like oropharyngeal airway and nasopharyngeal airway. You may use suction. Definitive airway, if still not improved, you have to call anesthesia. The anesthesia may put a tracheal tube, endotracheal tube, or if it is difficult, they may do more intervention like cricothyroidotomy. So the airway management, at the time of airway management, someone have to protect the cervical spine during airway management. Although the priority is for airway, but always keep in mind that if the patient have cervical injury during trauma, you might increase that problem. So the basic technique is, one of them is chin lift maneuver. The chin lift, you just elevate the chin. You do not move the neck. You do not move the neck. I will show you a video right now, but please, in this video, it contains both head tilt, chin lift. In trauma patient, head tilt should not be done because it might cause more trauma to the neck if there is suspected neck injury.
In cases where you do not suspect a neck injury, lift the tongue away from the back of the throat and open the airway by using the head tilt chin lift technique.
Position the patient by supporting the head and neck and placing the patient on his or her back. To open the airway, Place one hand on the forehead and place the fingers of the other hand under the point of the chin. Push down on the forehead and lift up and forward.
So this was for the chin lift. It is better to do jaw thrust in patients with trauma.
If you do suspect a neck injury and the patient is already positioned on his or her back, you can open the airway by using the jaw thrust technique. To properly perform this technique, place your fingers behind the angles of the patient's lower jaw and move the jaw upward. At the same time, use your thumbs to open the mouth slightly. The jaw thrust technique should open the airway without extending the neck.
The basic adjuncts for trauma is oropharyngeal airway to protect to open the airway, and also nasopharyngeal airway. So the oropharyngeal airway, if tolerated, it is a good modality. But if cannot be tolerated, example, if the patient is having gag reflexes, or if the patient is having vomiting, you have to put a nasopharyngeal airway. So this is oropharyngeal airway.
Welcome to Airways Surgical Private Limited. Dell
It has
Airways.
different sizes.
Measure the distance from angle of the jaw or earlobe to the nostril of the patient. Select the appropriate sized Dell Airways. It contains easy size identification with color coding. It contains reinforced pipe block. Lubricate it with water-soluble lubricant. Start to insert Dell into the mouth. Insert with curve facing the opposing direction.
So this was for the oropharyngeal airway. Now nasopharyngeal airway.
Nasopharyngeal airways are produced in a variety of sizes to accommodate various patients. To select the correct size nasal airway, begin by visualizing the patient's nares and select a nasal airway with a diameter slightly smaller than the patient's largest nare. Once the diameter is determined, then measure the device from the tip of the patient's nose to the tip of the earlobe or angle of the jaw. The rubber washer or grommet can be slid back and forth on the device to ensure a proper fit. Lubricate the distal surface of the airway with water or a water-soluble lubricant. If inserting the nasal airway into the patient's right nare, insert so as to follow the normal anatomical curvature of the nasopharynx with the bevel toward the septum. Direct the nasal airway along the floor of the nose into the oropharynx. If inserting the nasal airway into the patient's left nare, it is necessary to invert the airway so the bevel of the airway remains along the septum. Once the nasal airway reaches the nasopharynx, rotate the airway 180 degrees to resume alignment with the normal anatomical curvature of the nasopharynx. Continue to insert the nasal airway into the oropharynx. Once the nasal airway is in place, the last step is to check for adequate air exchange.
I have to tell you two other things, that if a patient can tolerate an oral airway, it means the Glasgow coma scale is very low. It means that the patient needs definitive airway, which is intubation. Another thing is that nasopharyngeal airway often well tolerated, but try to avoid it in patients with mid-face fracture because there might be basal skull fracture and go wrongly to the brain. Another important thing is when the patient is not ventilating, the patient have no adequate breathing or apneic, you have to use ambo bag. How to use ambo bag, I will show you through this video.
Gently cover the patient's nose and mouth with a face mask. Create a firm seal with one hand. Use your thumb and index finger to form a C on top of the mask. Spread the other 3 fingers along the patient's jawbone in an E shape. Hold tightly but not to press on the soft tissue below the jawbone. Tilt the head slightly backwards and lift the chin up so that air can enter easily. Deliver rescue breaths by squeezing the embryo back with one hand about 1/3 to half of the balloon.
Okay, so the summary of steps of assessment and management of the airway during trauma patient. First thing, talk to the patient. So talk to the patient. If responded, it means the airway is patent. If not responded, look for the airway obstruction, for swelling, for any foreign body, feel for the movement of the air, and listen for noisy breath. Then if there is a problem in look, feel, listen, you have to open the airway with the maneuvers like head tilt, no head tilt in trauma, chin lift, or jaw thrust. Then if there is anything that is necessary to do a suction, do a suction. Then use simple airway adjuncts like oropharyngeal airway. If the patient is not tolerating, example, vomiting, you have to put nasopharyngeal airway. Then, despite simple airway adjuncts, still the patient's airway is not good, or the patient needs definitive care, you may put a laryngeal massic airway or IGL. These are just temporary. They are not definitive airway, but they are more advanced than OPA and NPA. And the best thing, if the patient is unconscious or the airway is not sufficient, you have to put endotracheal intubation. If endotracheal intubation cannot be done because of difficulties, the anesthesic doctor may try it second time with boogie, with other things. If cannot be done, then cricothyroidotomy. They do an incision between the cricoid cartilage and thyroid cartilage and put an airway. Sometimes this is difficult. They just put a needle and give oxygen temporarily through a needle by oxygen. If the patient is not breathing or inadequate breathing, you have to use bag valve mask, or it's called ambo bag. It's also important not to forget to provide oxygen to any patient who is hypoxemic. So give 15 liters per minute, 100% by using reservoir mask, whether with the ambo bag or whether with the simple face mask. Next, coming to the breathing. So when you want to check the breathing, you have to look for the chest movement, whether it's moving bilaterally or not, if there is any lesions on the chest, any lacerations, any wound. Also check the respiratory rate, measure the respiratory rate. It should be between 14 to 20. Assess air entry by stethoscope, and also oxygen saturation by using pulse oximetry. Assess and ensure adequate oxygenation and ventilation. Oxygenation is different from how? Oxygenation means you provide oxygen to the patient, while ventilation means the patient is not ventilating well. You are using ambo bag. When you use ambo bag and connect it to oxygenation, both processes happen at the same time. I mean, you are ventilating a patient and providing extra oxygen to the patient. What are the immediately life-threatening chest injuries? So we are in the breathing. We have to talk about immediately life-threatening problems. Laryngotracheal injury. This is one. Second, tension pneumothorax. Third, open pneumothorax. Fourth, Flail chest and pulmonary contusion. Fifth, massive hemothorax. Sixth, cardiac tamponade. Nowadays, they don't regard this as an immediately life-threatening problem. Coming to the airway obstruction. Rarely airway will be traumatic and obstructed, but you have to check for hoarseness of voice, check for any subcutaneous emphysema around the neck or in the upper chest. Manage the primary survey as soon as possible. So you may intubate the patient with a tracheostomy, or you do tracheostomy. So this is the job of doctor of anesthesia and ENT. Tension pneumothorax. Tension pneumothorax is not uncommon in trauma patient. So check for the respiratory distress. If there is tension pneumothorax, the patient will be in shock. Why? Because when there is air going inside the pleural space and pressing the lung, then pressing the mediastinum, pressing the heart and the great vessels, it will now not allow enough blood to go into heart. So that's why it causes shock. There is also distended neck veins, so the neck veins will be distended. Absent breath sounds at the site of the pneumothorax. There is hyperresonant on percussion. There is elevated hemithorax. There is cyanosis, which is a late sign. So what you do, you have to do immediate decompression. What is immediate decompression? Nowadays, they suggest to put a needle in the fifth intercostal space. In the fifth, this is the first, second, third, fourth, fifth. So they put a needle in the fifth intercostal space in mid-axillary line. So here at that area. Previously it was in the second intercostal space, mid-clavicular line, but now they changed the position. Then if available, you have to put, this is a needle decompression followed by a chest tube. Please, if you are suspecting tension pneumothorax, do not send the patient for X-ray. The diagnosis is clinical. If you are not sure, then you may also do a fast scan. A fast scan can tell you if there is barcode sign. When the patient is having barcode sign, it is for sure this is a case of pneumothorax, and you have to start needle decompression and chest tube insertion. If a patient have open pneumothorax, I mean if the patient have a wound and this wound is sucking air and the patient having ineffective ventilation and dyspnea, what you do? You have to put a three-sided adhesive taping. So you put something, a nylon or something like that, you tape three sides in order for the air to go out through that and do not let come. So this makes a one-way valve that during inspiration the air goes out, during expiration it will not go in. And then after that you have to put a chest tube not on the side of the wound, at another side. Then definitive operation needed to close the wound by the cardiothoracic surgeon. Flail chest when there is fracture of 2 or more ribs in 2 or more sides, because there will be paradoxical movement of the chest. During inspiration, the chest expands, but that flail segment goes in, while during expiration, that flail segment goes out. So there will be hypoxia, there will be pain. So you have to give oxygen and put a tape along on the chest in order for that part to be splinted and move as one part with the skeleton. Also, judge's fluid. Don't give too much fluid in these cases because there might be underlying pulmonary contusion. Also give a good analgesia in order to prevent to make the patient having enough inspiration and expiration. Massive hemothorax. What is massive hemothorax? When the patient is having a lot of blood inside their pleural cavity and it is more than 1,500, there will be decrease in the breath sound, there will be flattening of the neck vein, there will be dullness on percussion. So no breath sound and percussion dullness. What you do is that if you put a chest tube, if more than 1,500 ml coming out, or the patient needs too much volume resuscitation, you have to call the cardiothoracic surgeon in order to intervene. Another indication to call cardiothoracic if the patient is having more than 200 ml continuously per hour in the next 2 to 4 hours of follow-up. So during the follow-up, you see that every hour there is more than 200 ml it means that the patient is in need of operation. Pulmonary contusion is not immediately life-threatening, but it might change later on, it might deteriorate. So this is pulmonary contusion on X-ray. Sometimes it would be very clear on chest X-ray. So it is very common. You have to oxygenate the patient and ventilate as necessary. Some patients might need intubation. The X-ray initially might be normal, so there might be delayed X-ray change. Do not give too much fluid because it might lead to edema. Okay, the next thing is circulation. Circulation, many patients with trauma, they die because of hemorrhage. So the first step when you go to the circulation, of course, you have to look for the level of consciousness. You have to look for the skin color. The first physiological change after shock is cutaneous vasoconstriction. That's why their color will be pale. Their temperature of the periphery will be very cold, so they will have a moist, cold hand. The pulse rate will increase. The character will be very thready pulse, very weak pulse. The blood pressure becomes down, especially in late shock. So you have to assess for organ perfusion. If the patient have decreased level of consciousness or anxious, mostly there might be a lot of bleeding. So what you do is that the first thing with the assessment, you have to control any obvious hemorrhage. Any obvious hemorrhage means external hemorrhage. So you control the hemorrhage, you restore the volume, I mean you give fluid. How much fluid you give? You have to give 500 ml boluses until you reach 1500. So they say it is better not to give more than 1500. After 1500, give blood. If blood, cross-matched blood not available, give O negative blood. So which fluid you give? Normal saline or ringer lactate. They are called crystalloid. Then after 1500, try to give O negative blood. If O negative blood, if cross-matched blood available, better to give cross-matched blood. But sometimes you are in hurry, you don't want to lose your patient, so give O negative blood until cross-matched blood is ready. At the same time, try to give fresh frozen plasma and platelet, especially fresh frozen plasma, because the blood that we are giving is packed red cell. It is not containing any plasma. You have to assess the patient for improvement or not. Some patients are very rapid responder. So according to your follow-up, some patients are rapid responder. It means that they are improving and not getting worse. Some patients are transient responder. It means that they are responding, then after a while they will deteriorate again. Some patients are non-responder. It means that they have too much bleeding, which is out of proportion of resuscitation. You have to provide special care for elderly patients because of their comorbidities. Special care for children, give it through KG. Athletes may have bradycardia. Medications like beta blocker, calcium channel blocker, or digoxin may affect the heart rate and does not let you to see the shock. Is my patient is in shock? How do you know that your patient is shocked? The first step, the most important step, I think, of management of shock is recognition of shock. How do you know that a patient is in shock? If the patient has altered level in consciousness or anxiety, anxious, cold, moisty skin, tachycardia, tachypnea, hypotension, decreased urinary output. These are the signs and symptoms of shock. What are the possible sites of bleeding? There is a quotation, always don't forget this. It said that one on the floor and 4 more. It means that you are searching for bleeding during trauma. 1 on the floor means external, and 4 more, it means 4 internal bleeding sites. What are these internal bleeding sites? You have to memorize this very good. From the chest, from the abdomen, third, from the pelvis, and finally from the long bone. And don't forget, with the abdomen, examine the retroperitoneal. So look at the flanks, because there might be missing bleeding. How do you know that a bleeding is in the chest? By examination. Also by chest x-ray, sometimes by fast scan. How do you not know that a bleeding is in the abdomen? There might be swelling of the abdomen, bruises, abdomen is rigid or tender, and on fast scan there is free fluid. How do you know that there is a bleeding in the pelvis? You just touch the pelvis one time, only one time, check the pelvis. There might be bruises around the pelvis, there might be your hand going out, so it means it's an open fracture. In pelvis, temporarily you can put a pelvic binder. Okay, long bones. How do you know that a long bone? Okay, in pelvis also you can do an x-ray. So x-ray here, and fast scan here. How do you know that a long bone is fractured? There will be deformity, swelling, and pain. So by this you can know that you can see the sites of the bleeding. Next, coming to the disability. Disability usually checking the brain. For example, you have to check basic neurological evaluation by checking which side the patient is moving, one side or both sides, or not moving at all. Glasgow Coma Scale is very important to know the degree or the severity of brain injury. Pupillary size. If one pupil is dilated and the other pupil is constricted, it might be a brain lesion. There might be a bleeding inside the brain causing pressure. So always observe for neurological deterioration. This is very important. The primary goal of treatment for patients with suspected traumatic brain injury is to prevent secondary brain injury. What is primary brain injury? Primary brain injury is the injury that happened during the incident itself. So during the accident, there is some brain injury that is not reversible, but the secondary brain injury is the injury that happens inside the hospital. Example, hypoxia, hypovolemia, hypotension, shock, or the patient is having increased CO2 retention. Sometimes there might be increased intracranial pressure, infections, and convulsion. So you have to prevent all this. Hypothermia. There is a concept of Monro-Kellie doctrine. Monro-Kellie doctrine says that brain is a confined space. Brain is a confined space that contains, the skull. Skull is a confined space containing brain, cerebrospinal fluid, and blood. So once there is a increased intracranial pressure by a mass, some CSF goes out and some venous blood goes out from the brain in order to let the space for the brain to do its function, because brain is not functioning when there is increased pressure on it. There is a level, they say, might be about 775 ml of each fluid, of each blood and CSF. If more than this going out, then there will be decompensation, in which no more decompensation, in which the patient is having pressure effect on the brain. So there are some types of epidural hematoma that you can classify. This is according to the morphology. For example, this one is epidural hematoma. This is hematoma outside the dura mater. It is biconcave shape. Classically, there is middle meningeal artery tear. It is biconvexous. There is lucid interval. The patient is unconscious, then become conscious, then he lose consciousness again. It can be rapidly fatal because it's an arterial. Early evacuation may be essential by a doctor of neurosurgery. We have another type called subdural hematoma. The subdural hematoma is between the dura and the arachnoid, in which there is venous tear. It is venous bleeding. The morbidity and mortality mostly because of underlying brain injury. It might need rapid surgical evacuation, especially if the midline of the brain have shifted more than 5 millimeters. Or the patient have signs and symptoms of increased intracranial pressure. Intracerebral hematoma might be single or might be multiple hematomas at the site of the impact or opposite to the site of impact. At this site, at the site of impact, it is called coup. At the opposite side is called counter coup, because brain is moving, so it will cause the bleeding at another side. Mostly it is frontal, sometimes it is temporal. CT changes usually are progressive, so you have to do repeated CT scan for evaluation. Diffuse brain injury, what is that? There is diffuse axonal injury in which the CT scan is normal, but the patient is unconscious or have decreased level of consciousness. It ranges from mild concussion to severe ischemic insult. So with follow-up, you can know the severity. Usually no need for intervention, but you just do ABCD. The classification of head injury, this was based on morphology. Now, based on the Glasgow Coma scale, we have mild, moderate, severe. The mild one is a Glasgow Coma scale of 15 or 14 or 13. The severe one, anything less or equal to 8. The moderate one is 12, 11, 10, or 9. So if mild brain injury, you just have to wait and to provide good care for the patient. Some of them may need CT scan. So CT scan, some of them, not all of them. Only if there is specific indication. But moderate and severe, do CT scan for all of them. And if there is moderate or severe brain injury, please, despite providing good ABCDE care, it means you prevent secondary brain injury and also give cyclocapron. The cyclocapron, which is the tranexamic acid. So you give this ampoule 1 gram over 10 minutes, then 1 gram over next 8 hours. If this given during the first 3 hours of injury, it will decrease morbidity and mortality. So we are giving cyclocapron for mild, moderate, and severe brain injury. Indication of CT scan, although this is changing, now they say any vomiting 2 and more times in adult. Glasgow Coma scale less than 15 or after 2 hours after injury. If there is any neurological deficit, if there is open skull fracture, if there is signs of basal skull fracture, example, panda eye, battle sign like this, or the patient is having rhinorrhea or otorrhea, when clear water, which is CSF, coming from nose or from the ear. Extremes of age no more is an indication. Retrograde amnesia and also severe headache. There are some other indications, some details, especially by the NHS. For example, in children, they say if the patient is vomiting more than 3 times, plus abnormal drowsiness, then you do a CT scan. A falling more than 3 meters may be an indication to do CT scan in children, while in adult more than 1 meter is enough to do that. What is the optimal treatment for patients with brain injury? You have to prevent secondary brain injury by provide good airway, good breathing, good circulation, and good disability. So you give oxygen, ventilate the patient if necessary, maintain blood pressure above 90 over 50, above 90 over 60. So at least the systolic should be above 90. What is a focused neurological examination? You are not a neurologist. You just want to assess the patient of a trauma. Just measure the Glasgow coma, examine the pupil size, and confirm whether the patient having movement of both sides or not. If there is any problem, consult neurosurgeon as soon as possible. So medical treatment composed of controlled ventilation. This is controlled ventilation is usually done after endotracheal tube is done and ventilation, assisted ventilation by a machine. So you increase the respiratory rate. You increase the respiratory rate in order to decrease the PaCO2 level. The normal PaCO2, which is measured on ABG, should be between 35 to 45. So you have to keep it at a lower level because CO2 by itself is a vasodilator. It causes more bleeding. So you want to decrease the CO2 level. IV fluid, you have to give, provide euvolemia, give isotonic like normal saline or ringer lactate. Consult with neurosurgeon as soon as possible. So this process is done by the intensivist. While giving IV fluid and also giving oxygen to the patient, head elevation is also an important matter. Head elevation, mannitol, use only when signs of tentorial herniation. It means when there is increased intracranial pressure, there is one pupil is dilated and the patient's level of consciousness decreases. And the patient repeatedly vomiting, having high blood pressure, low pulse rate, respiratory irregularity, shallow respiratory irregularity. So these signs are of Cushing triad. So if the patient have Cushing triad or other signs like pupillary dilatation on one side, you have to give them mannitol. The mannitol, the dose is 1 gram per kilogram of weight of the patient. Usually the mannitol that we have is 20%. It means 20 gram in every 100 ml of mannitol. If a patient is hypovolemic, do not give mannitol because mannitol can lead to more hypovolemia because mannitol is an osmotic diuresis. The dose is 1 gram per kg IV bolus. If you don't want to give mannitol and or it's contraindicated, you can give hypertonic saline. So normal saline is 0.9, but hypertonic is 3%. If available, you have to give 5 ml per kg over a period of 15 minutes. So this is a substitute for mannitol. Anticonvulsant, you may give diazepam, lorazepam, Keppra or phenytoin, phenobarbital in order to prevent further brain damage. If the patient is unconscious, you sedate, you give paralytic, you intubate the patient. Please don't forget tranexamic acid. So any patient with moderate or severe brain injury, you have to give tranexamic acid. As we said, 1 gram in 10 minutes, then 1 gram in 8 hours. If there is a scalp wound, surgically you have to search for the site, or possible site of major blood loss. So it might lead to too much bleeding and causing shock, especially scalp wound. So direct pressure to control the bleeding. Sometimes you may do an occasionally an temporary closure in order to prevent the further bleeding. Any penetrating trauma, you have to give you have to do an ABCD, and then doing X-ray or CT scan to know the extent of injury. Early neurosurgical consult, because they have to suture it or they have to do surgery. Give up antibiotic and anti-tetanus. Give prophylactic antibiotic and anti-tetanus. Do not remove any penetrating object in the brain, and do not probe the wound to know the extent of the injury. Exposure, it means that you have to completely undress the patient and prevent hypothermia by recovering the patient with a blanket. So prevent hypothermia, and also you can see any missed injuries. So what was our resuscitation? We ensured a patent airway. We secured the C-spine. C-spine X-ray is not done in the primary survey. Detection of the C-spine injury is only done in the secondary survey. So you say that protection is priority and detection is secondary for C-spine. Ventilate and oxygenate as appropriate. Stop the bleeding. The patient may need crystalloid, normal saline or ring-lactate, blood resuscitation and other blood products. Protect from hypothermia. If you do this, it means that you have resuscitated the patient appropriately. And of course, you have to call for help early. What are the adjuncts to primary survey? It means what are the things that helps you to assess the patient management. Vital sign and repeated vital sign is essential. Bloods, so you may send for complete blood count. Blood group and RH is very, very necessary in every patient. Sometimes you may send for virology. This is especially in patients who are absolutely needing surgery. So you prepare them for surgery. IBGs sometimes may help you in assessing the patient. Pulse oximetry, always check their pulse oximetry and repeatedly assess them. Urinary and gastric catheter. Urinary catheter is important to assess the urine output. But if you are suspecting or there is a pelvic fracture and you are suspecting urethral injury, do not put a urethral catheter. If there is blood on the meatus, just call the urologist. They will deal with the condition. They may do a trial, they may do ascending urography. Whatever they do, it is their job to control the urinary catheter. Gastric catheter is essential because gastric catheter can decrease the gastric distension and improves breathing, but it is contraindicated if there is suspicion of basal skull fracture or midface fracture. Urinary output is essential to measure it to know whether the patient is having shock or not. ECG, especially if the patient is suspected to have cardiac contusion, if they have a chest injury. The diagnostic tools that you are using during primary survey, the radiology that you do are only chest X-ray. This is one. Second, you use a pelvic X-ray. Of course, these are used in the resuscitation room. And the third one is fast scan. So these are the only radiologies that are allowed during primary survey. If a patient is unstable, it's not allowed to send them for the CT scan or MRI because they may deteriorate there and die on the table of CT scan. So other diagnostic tool is fast scan. Previously they were doing diagnostic peritoneal lavage. Nowadays they don't do it too much. Consider early transfer of the patient, especially if it is necessary to transfer a patient which capability is not available in your hospital. For example, you are in a hospital, there is no neurosurgeon and the patient needs brain surgery, so you transfer them. Do not delay transfer for simple diagnostic tests. For example, you send a patient for a wrist X-ray and the patient is having a very severe brain injury. So this is a fatal mistake. Now we completed the primary survey. If the patient having a good resuscitation in improving in vital sign, we start secondary survey. What is secondary survey? Secondary survey is a complete history and physical examination, and also using some adjuncts. So when do you do, which time you do, you start secondary survey. After primary survey, ABCDE done, and during ABCD you found life-threatening problem and treated, and vital functions returning to normal, and after reassessment you have to do secondary survey. The components of secondary survey are 5 things. First, history. You have to take an ample history and a short history. Then physical examination from head to toe. Then complete neurological examination. This is the time when you examine the neurological status of the patient in detail. Fourth, special diagnostic test. You may need a CT scan, an MRI, or you may need an endoscopy or laparoscopy. So anything that is essential. And then re-evaluation. You re-evaluate the patient before sending for definitive care. What we mean by ample history? A stands for allergy. If the patient is allergic to any medication, the medications that already using, because they may have impact on the injury. For example, the patient is using a diuretic, an antiplatelet, anticoagulant, beta blocker, any past illness that influences the management of the patient, pregnancy. As you said, you have, if any lady who is at the age of pregnancy, you have to send for pregnancy test, because at that time you are treating 2 people. Last meal. The last meal is essential, especially when you want to intubate the patient because of risk of aspiration pneumonia. The event is that causing that problem. For example, a patient have a chest pain, then lost consciousness, then have a road traffic accident. It means that they might have an MI. The environment, whether it was a cold environment or a hot environment, the mechanism of injury. I always say to my students is that you have two child 1 and child 2. These 2 have injuries. The first one is age 4 years. Second one also 4 years. They have vomiting 1 time. This patient also have vomiting 1 time. Everything is similar, but the mechanism of injury of the first one is that he fall from to the ground in a half meter. The second one have fallen in a 2 building, might be 4 meters, both 4 meter. So both of them, they have the similar presentation, but that patient especially, you are suspecting worse injuries, and you may keep them for a longer time in the hospital because you say that this child might get deterioration later, but that one having no any other issue, you after 1 hour or after half an hour, you tell them to eat something and then discharge. So that's why mechanism of injury makes you to suspect it, the problem. Another thing, when a patient is in a confined space and there is a burn, so at that time there might be burn plus inhalation injury or cyanide toxicity. There is a road traffic collision. There are 2 people inside this car. one died and the other one presenting normal to you, you have to have high suspicion of getting complications. So this was the history. Then coming to the examination from head to toe. In the head, you have to examine the head externally, scalp palpation, do a comprehensive eye examination and ear examination. How the eye is examined? By ABCDE. The A, you have to look for the visual acuity. B, bright light reflex. So you put a light on the patient, bright light. C, look for the cornea and conjunctiva. D, examine the disc by ophthalmoscope. If not available, no problem. Just go to the last step, which is eye movement. Ask the patient to move their eye. If there is trapping of eye in a side, it might be due to trapping of a muscle. So if the patient have no ABCDE problem of the eye, then you just go ahead. If there is a problem, you have to call the ophthalmologist. Examine the ear, both externally and internally. Sometimes auditory canal is occluded, no problem. You just tell them to return after 5 to 6 days to be checked by ENT doctor. Sometimes periorbital edema makes you it makes the examination very difficult. Also, sometimes there might be, you also examine the teeth, the mouth of the patient. If there is a missing teeth, you have to search by X-ray. It might go into the chest. Maxillofacial, check for bony crepitus, any deformity. Ask the patient to open their mouth and then close it in order to see whether their occlusion is good or not. If there is any problem, you may do a CT scan of the face and call the facial-maxillary doctor, surgeon. There might be potential airway obstruction, especially if a patient have jaw fracture, bilateral jaw fracture, makes that part free. During lying down, the jaw goes inside and obstructs the airway. Or if there is continuous bleeding in the facial-maxillary area, it also leads to obstruction. So you may need to intubate the patient. In the neck, you have to search whether there is blunt trauma or penetrating trauma. Look for airway obstruction, listen for hoarseness of voice, check for any crepitus, hematoma, stridor, bruit by putting a stethoscope on the neck. There might be delay signs and symptoms of airway obstruction, progressive airway obstruction in burned patient. Occult injuries might be there and you don't feel it. In the secondary survey of the chest, you have to inspect, palpate, percuss, auscultate, X-ray as necessary. So, for example, this patient is having seatbelt sign. The seatbelt sign, you are expecting that there might be fracture of the clavicle of the first and second or third ribs. There might be cardiac contusion, pneumothorax, hemothorax. There might be gastric injury and also liver injury. So according to the type of injury, you have to expect many findings. In the abdomen, you inspect, auscultate, palpate, percuss, re-evaluate. Special tests might be used. Apart from ultrasound of abdomen, you may need in the secondary survey. You are having a stable patient. You may need a CT scan or a CT scan with contrast. There are some difficulties in examining hollow viscous injury. So there might be, for example, a duodenal injury that only can be detected by endoscopy, by OGD. Retroperitoneal injury is difficult to be examined by ultrasound. You have to consider this as well. The perineum, look for contusions, hematoma, laceration, evidence of urethral blood. In the rectum, you have to examine the sphincter tone for any neurological deficit. Pelvic fracture, because it might be a source of the bleeding. Rectal wall integrity, and also if there is any blood. Vagina should be examined to see if there is any blood, any laceration. So always you have to expect urethral injury and pregnancy in any female of childbearing age. Pelvis, you have to suspect it by the mechanism of injury. So in this patient, there is pelvic injury. There might be pain on palpation. Leg length discrepancy, leg lengths are unequal. Instability is a problem, so you put a pelvic binder to prevent further bleeding. X-ray as needed. Do not do excessive pelvic manipulation, because there might be a clot that already formed and you excessively moving the pelvis and you cause dislodgement of that clot and further bleeding. Do not underestimate pelvic blood, because it may lead to 5 or 6 liters of bleeding. Check the extremities very well. Check for contusion, check for deformity, check for swelling. Examine the pulses for peripheral perfusion. Check their capillary refill time. Examine their neurological status by power and by pinprick examination for sensory. X-ray only as necessary, only the areas of interest that you suspect it changes the management of the patient. Musculoskeletal might be a potential blood loss might happen. Example, in a fracture of femur, each femur may lose 1.5 liters of blood. Missed fractures, soft tissue or ligamentous injuries, compartment syndrome. So you have to examine the musculoskeletal system in a very detailed way in the secondary survey. Going back to brain, perform a Glasgow Coma scale. Look for the pupil size and reaction. Examine whether the patient is moving or not, both sides, lateralizing side. Frequently re-evaluate the patient. Prevent secondary brain injury. We talked about this sooner. Early consult neurosurgery if there is any problem. For spinal assessment, whole spine should be assessed for tenderness and swelling. Sometimes you have complete motor and sensory problems because of complete dissection of the spinal cord. Sometimes you have incomplete injuries. The incomplete injuries, no need to talk you about this in detail. We have Brown-Sequard syndrome, we have anterior cord syndrome, we have central cord syndrome. This is difficult to memorize. Anyhow, you also examine the reflexes and do imaging studies as necessary. You may need a CT scan to detect the bony integrities of the spine. You may also do an MRI in order to see the soft tissues, the ligaments and the spinal cord, and the spinal cord itself. So you have to conduct an in-depth evaluation of the patient's spine and spinal cord. If there is any problem, consult neurosurgeon. And another important issue is that we say during airway you have to protect the airway and protect the C-spine by a collar. Also, if you put this one, which is called sandbag and taping of the head of the patient and chin of the patient, and also putting a spinal board under the patient. In this way, you are completely immobilizing the patient during transfer. But when the patient arrives to the hospital, you have to check them in order to know whether they need this or not, because leaving a patient on spinal board for longer than 5 minutes might be very irritable and it might lead to pressure sores. Incomplete immobilization might happen and might lead to neurological deterioration. So the adjuncts adjuncts to the secondary survey. Now we are using adjuncts like CT scan, MRI, endoscopy, OGD, colonoscopy. During this, the patient might deteriorate. You may delay this, delay transfer of the patient because of this test. There might be poor communication. There might be inappropriate testing. You send for a brain CT and they do a CT of the chest. So there are many problems that are happening during this. You have to be careful. How do I minimize a missed injury? By having high index of suspicion. So if a patient have a very bad mechanism of injury, you examine them very thoroughly. Frequently re-evaluate and monitor the patient. The pain management is to relieve the pain and to relieve the anxiety of the patient. The pain management during major trauma should be IV one. Better to give morphine or pethidine or tramal or paracetamol. Non-steroidal anti-inflammatory drug is usually not recommended. But anyhow, if you give these drugs, you have to carefully monitor it, because if you give too much, it might lead to apnea, or too little will not be enough for pain management. Sometimes you face a problem of giving opioid and the patient's conscious will deteriorate. So it is better to assess the patient's neurological status. I mean, just a basic evaluation of the neurological status before giving opioid. If you couldn't examine them because of shouting of the patient, because of severe pain, just give the painkiller and don't wait. Transfer. Which patients do I transfer to the higher level of care? This is all those patients where their injury exceeds or more than my institutional capability. My institution, for example, cannot let me to do a cardiothoracic surgery, and my patient is having massive hemothorax. So I just give fluid and blood and resuscitate the patient, sending them directly to the other hospital. If there is multi-system or complex injury, patients with comorbidities and extreme ages also might be needing to transfer to other hospital. When the transfer should occur, the transfer should only occur as soon as possible after stabilizing measures are completed. It means the airway ventilatory control being done, hemorrhage being controlled, sometimes even operation might be done. Secondary survey is not an issue. You can delay the secondary survey, but you can write down that I have done the primary survey. Secondary survey is delayed because of rapid transfer need. The local facilities have to be agreed on. So you have to know which patient to transfer to which hospital at which time, which doctor you talk. So which local resource you have, the agreement is, and also retrieval coordination center. There should be a coordination center between the hospital to tell them that I have a bed or not. For example, you send a patient for CT scan to another hospital, and then turn it to be their CT scan is also not functioning. So you have to call them before sending a patient to that hospital. In the summary, you have to prepare yourself by a good education about trauma, by having a good trauma room, an equipped trauma room, a good team which are understanding each other in the language of trauma. So everyone knows their role in the trauma team. There will be a common language between them. Then when a patient arrives, you have to do primary survey. If there is any problem, you resuscitate the patient, use the adjunct, then re-evaluate the patient. If the patient not improve, you do primary survey again. If the patient improve, go to the secondary survey. In the secondary survey, you have to use the adjuncts, detailed history and examination should be done. Then after that, you do the definitive care. Thanks a lot for Hausung organization for preparing and for organizing the slides, and this was in collaboration between the Hawler Medical University College of Medicine and Kurdistan Society of Emergency Medicine. Thank you.